If you don't know me, if you don't know me, I'm a professor of language and communication disorders here at UCL, and a speech and language therapist by training. But I'm very interested in the overlap between language disorders and other neurodevelopmental conditions like autism and ADHD, which we'll hear about today. And I proposed this topic. And the reason I did is that I support a lot of speech and language therapists who are working in the NHS, and this is a growing consideration for them. And two things really stood out. So one is one of the rare speech and language therapists who works in the neurodevelopmental clinics. And their descriptions of what happens when a person goes for a diagnosis of autism or ADHD and actually comes away with a diagnosis of DLD, so not the one they were expecting, which is really interesting. And the other was a clinician who works for an autism diagnostic service, where in order to meet demand, what they decided to do was to remove diagnosis as a barrier to accessing support. So children were no longer required to have a diagnosis before they got an EHCP or specialist support in schools. And actually, that's done nothing to reduce the number of people who are coming forward for diagnosis or to reduce the waiting lists. So both of those things, I think, present interesting challenges. And I know that this is a growing issue in many aspects of children's mental health. So I'm really delighted to have two speakers with us today who can give us both a clinical and a research perspective on what's going on. And I'm really looking forward to what I'm sure will be a rich discussion. So without further ado, our first speaker is visiting us all the way from King's, Professor Philip Shaw, who's the director of the King's Maudley Partnership for Children and Young People. And his talk title is there an increase in neurodevelopmental conditions and what's causing it? Over to you, Philip. You're on mute, Philip, sorry.
There we go. That was a good start. Hi, Rick. Can you hear and see my slides okay? Oh, can you hear me okay?
You're good.
Yeah, okay, great. Well, thanks ever so much for the invite. It's a pleasure to be here today. So my name's Philip. I'm the director of King's Maudley Partnership. So yep, as was said, I'm all the way south of the river coming to you virtually, and it is lovely to be here with you all today. So I'm going to talk mainly about the possibility of an increase in ADHD, because that's the sort of my area of main interest. And I'm going to focus on three things. First of all, I'm going to ask, is there an increase? And if there is an increase, how large is this increase? If there's an increase, what's driving it? What are the possible causes? And if there's an increase, how can research help us go forwards to meet the challenges of ever-increasing rates of ADHD? So I'm going to start off by saying, how big is this actual increase? Now, the data we have is actually remarkably, in some way, very, very sparse. Now, the best data we had was this fantastic database, which was based out of GP surgeries. About 10% of all GP surgeries fed into this database, and it covered data from the year 2000 to 2018. So we have some really, really good knowledge of what was happening to diagnostic rates over that period. And as you can see, I don't know if you can see, can you see my little marker here? Oh, well, anyway.
We can. Yes, we can.
Wonderful, wonderful. So along the x-axis here is the year, and along the y-axis is the number of recorded diagnoses per 10,000 individuals. So, it shows the thing that you would expect with an increase, everything sloping upwards. But you really got to dig down into the details to see what's going on here. So here, these are clearly the ones who are showing most increase, and these are teenage boys. Clearly, it goes from quite a low rate of 100 per 100,000 up to about 350 per 100,000. So what that means, to put it simply, is in 2000, roughly over 1% of kids in GP surgeries were getting a diagnosis of ADHD. It went up to about 3.5% for little boys and teenage boys. For girls and for females, the rate went from a very low 0.2% to about 1%. And of course, the biggest increases were for adults. You can see really a very marked increase here. But again, it's important to appreciate where things end up. From 18 to 29-year-old males, it went from an extraordinarily low rate indeed, up to about 3%. And for females, it went up from an almost undetectably low rate in 2000 up to about 0.8%. So there's a definite increase. There's a definite increase in UK-based diagnoses in primary practice. Highest prevalence of diagnosis, 3.5% in teenage boys, 1% in girls. However, you've got to put all of that against the context of if we were to go out as researchers and to do our gold standard interviews in the community, and we were to go through in a very detailed, long, research-based questionnaire to ascertain all the symptoms of ADHD, what age did they start, how much impairment are they causing you or your child across different aspects of life, this would probably come out at a prevalence rate, a population evidence of about 5% for young people under 18 and maybe 2% for adults. So even with the increase to 2018, 3.5%, a little bit below what we think is the true research accurate prevalence of ADHD in the community. Now, since then, those really rigorous databases have gone, and so we have to look at other sources. And here's a very nice one from the CAM services of South London, and this is data from the Digital Lab. And here what they've done is they have got the numbers of kids in South London who were diagnosed with ADHD and divided it by the number of kids who are on school registers. So this gives us an approximation again of how many kids in the population are getting diagnosed by ADHD. And you can see here it is going up. So this was in 1993. This was in 2003. It goes from about 0.8% to 2%. If we continue to follow it, it'll go up a little bit more. And again, it ends up at roughly about 3%. So 2% diagnosed with ADHD up to 2003 goes up to about 3% whenever we go to more recent figures. But it gives you an idea that we're still somewhat below the 5% range. By contrast, the other ways we can look at it is to look at ADHD medications. This is in some way the most objective measure we have. There are 5 medications that are licensed in the UK for the treatment of ADHD, and there are wonderful registers kept of how many items are prescribed for every 1,000 individuals in the population. And these are the figures. So it goes from 25 prescriptions for ADHD medications for 1,000 people in 2020, and it doubles, nearly doubles, up to 2023, an annual average increase of about 18%. However, again, it's important to translate that into something that's a bit more meaningful. And if we look at it in population terms, it means that in 2023, roughly 1 in 200 individuals, 0.5% of individuals were on psychostimulants. Again, that is way much lower than those who we think have diagnosable ADHD in the community. So that's what we medically recognized or treated ADHD. What about the experience of ADHD and its symptom, the self-reported experience of ADHD? Is that changing in the community? And here we rely on survey data. These are normally self-reported data for adult using a questionnaire which is held stable over time. The one that's particularly useful in the UK is from the Adult Psychiatric Morbidity Survey, and the screening questionnaire is a very good, free, quick one. And it suggests, again, here is year. So this is 2007. This goes right up to 2024. And you can see there's a bit of an increase. The increase is biggest for this age range, which is 16 to 24-year-olds. It goes up. These are individuals who would screen positive for ADHD. In other words, they're saying, oh yeah, I had quite a lot of symptoms. So it goes up already from quite a high 14%, but it increases up to about 25%. Now remember, this isn't talking about, oh, these individuals all definitely have ADHD. It absolutely is not saying that. It is saying these individuals are reporting symptoms of ADHD, which might then trigger a process of further assessment. But again, there is a suggestion that the experience and the reporting of symptoms of ADHD is increasing in the community, certainly in young adults. For kids, I think the picture's a little bit more complicated here. I think the best data, because again, it's been repeated without change over time, comes from the Understanding Society data. It uses something called the Strength and Difficulties Questionnaire. So if we look here, these are emotional problems, and yet the lighter color are girls, the other one is boys, and you can see emotional problems are increasing more for girls than for boys over time. This is 2009, this is 2022. Psychological distress is going up, taking a marked peak during COVID and then coming down a little bit, but going up. But look at hyperactivity, which is one of the core features of ADHD. There, it's a less convincing pattern of increase. It might be going up for females, or that might just be a temporary blip. So for children, and again, this is parents reporting on their kids, actually the symptoms out there in the community don't seem to be increasing too much. Not the case for adults who are reporting more symptoms, especially young adults. So how do you summarize all that complex stuff? Well, there is a definitely an increase in ADHD diagnosis in the UK, definitively from 2000 to 2018, where we have our best data. Since then, more indirect evidence suggests that there is a modest ongoing increase, but it's actually quite hard to quantify it exactly. There does also concomitantly seem to be a possible increase in the experiencing and reporting of ADHD, the actual prevalence that's occurring outside of our medical system. Nonetheless, it's still important to recognize that the research gold standard estimate of our best estimate of the true rate of ADHD in the UK population, even our current diagnostic rates are still somewhat below that. So why is there such an uptick then in people seeking assessment for ADHD and a possible increase in the experiencing of ADHD symptoms themselves? Well, there are many, many different explanations. I'm not going to go through each one in detail. I'll just outline 6 theories and then take a deeper dive into a couple of them. The first one is that we are playing a game of catch-up. As many of you will know, many years ago, ADHD was scarcely under-recognized, particularly in adults. So the rate of diagnosis would have been about 0 point something percent. That's way below the population true prevalence of ADHD. So it's going to take our services a long time to catch up to the true population rate, and we're simply not configured for that at all. These services aren't expanding, hence the long waiting list. There's a process of catching up. We're going from an extraordinarily low baseline to something that comes a little bit closer to the population prevalence. The other possible explanation to consider is that there's been medical shifts, changes in our diagnostic practice of ADHD. Are the symptoms that individuals need to report, particularly around impairment, has that shifted in the interaction between care providers and someone who's presenting with ADHD symptoms? Is the boundary where we draw a cutoff and say, yes, you have a diagnosis of ADHD, is that shifting with time? And on the side of those with ADHD, is there a shift in how ADHD is being experienced and expressed? Is it possible, for example, that ADHD is being used as an expression, a metaphor, to express challenges and distress? Something I'll unpick a little bit later. Could it be COVID? Everyone is so struck by the sudden disastrous removal of all learning structures and the structure of everything for a couple of years. Could that be driving this increase? Very popular theory is that it's social media somehow rewiring the developing brain. And then the last school of theories would be around it's just a tough life out there. It is just really difficult to be a kid, particularly a kid who has any form of attentional differences. The increasing pressures of life are making any child who is a little bit attentionally, has a different attentional style, impairment is being heaped upon them by the increasing demands of school and life in general. So let's just unpick them a little bit. I'll look first at the social media theory. This idea very much popularized by the idea of rewiring the developing brain. But if we look at the actual data, it's actually pretty modest. There are now vast meta-analyses of the association between online technology use, particularly smartphones and tablet use, and poor mental health outcomes. There's this lovely meta-analysis, which was of 143 studies, over 1 million young people in this. And it suggested that, yes, engagement with social media was associated with a slight increase in internalizing symptoms, but this is a tiny, this is an effect size. This is a very, very, very small effect. This means, it's incredibly significant because there's 1 million kids in it, but the actual size of it is very, very small. On a population term, you're talking about a tiny shift here, a tiny amount of the shift in internalizing symptoms. If you accept this association as a cause, which is a jump, even if you accept that, it's only going to cause a tiny shift. There was another very nice, somewhat similar meta-analysis, which included about 7,500 kids, all child level outcomes. And this included ADHD, which is why I'm highlighting it. None of them were great. And so social media. Oh, sorry. So I think someone's unmuted. Sorry. Hi. Sorry. Thank you. So this is a study about ADHD outcomes. Again, all of the outcomes, all of the associations with social media use at a population level were unfavorable, but the effects were absolutely tiny. If it's there, it's only part of a very complex study. The associations are modest. And what's interesting, actually, is that these associations were not moderated by the year of publication of the study, suggesting that things probably, as far as we can tell by doing this sort of retrospective look at cross-sectional studies, as far as we can tell, things aren't getting worse with time. But, nonetheless, is there a causal link? All of those were cross-sectional studies. Is there any evidence to suggest that social media is driving poor outcomes? Well, we haven't yet done the sort of very large-scale experimental studies, experimental interventions that would give us a definitive answer. But we can start to look at longitudinal data, for example, to at least determine the direction of effects. So here we can use longitudinal data to see whether social media drives adverse outcomes such as depression, or is it the other way around? And here I'm not putting up ADHD because that didn't appear at all, just to put that out there. And what we find here, these things are called cross-lag analyses. It's saying what drives what. It puts everything in one big statistical model and pulls out which pathways of effect are significant. So social media, if you use social media, whenever you're age 6, say, you're very likely to use it at age 9. No surprise there. If you have some depressive symptoms here, you're likely to have some depressive symptoms later. No surprise there. But what we're really interested in is these things. Now, this is saying that having depressive symptoms here doesn't drive you at a later stage to be using more social media. It's not that kids who are sad are going home and using more social media and then it feeds back. That's not what's happening. Here, it's saying that social media use, whenever you're young, is likely controlling everything else to slightly increase your depressive symptoms at a later stage. This is moving beyond association. It's just hinting in the direction of cause by looking at the direction of effects over time. Again, it's really important to look at these numbers here. This is the effect size. This is a tiny effect size. So again, if there is an effect, and if we accept that was causal, which again is a big leap, it's a very, very, very modest contributor. So what about the idea that things are just tougher out there? Well, they are tougher out there. There are tougher economic conditions, particularly around cost of living in the UK. There is an indisputable increase in the cost of living for most individuals since 2010, and it could be playing a role. The other one that people often focus on is the possibility of poverty and income inequality, although that feature, unfortunate though it is actually reasonably stable, so alone isn't likely to be driving the actual increase. What about an increase in academic pressure? Well, World Health Organization cross-sectional studies, there's some very nice ones. It found that actually over time in the UK anyway, over repeated serial surveys, kids weren't reporting that they were feeling more stressed out. However, some studies that took slightly deeper dives did suggest that maybe there is, not only is there an association between academic pressure and worsening mental health, again, more in the mood and anxiety cluster than in ADHD, And these effects here did seem to be increasing very slightly over time. But again, these are cross-sectional studies, and if it explains anything, it's only going to be a tiny bit. And what about COVID? Well, we're at the stage of studying COVID and its effects on mental health that we can do reviews of reviews. And there are now 5 of these reviews of reviews, and they all pretty much say the same thing, that the pandemic has been associated with worsening mental health, particularly mood and anxiety symptoms, not so much ADHD symptoms actually. Again, much more the internalizing cluster. However, if you look at all of these studies, particularly the longitudinal ones, you can see a really interesting line. They sort of go along. It definitely peaks during the pandemic, particularly at times of lockdowns and school closures, but then it tends to drift back down to where it would have been anyway. And the increase for kids anyway is much more marked in self-report than in parental report. And the other important thing to remember is that this increase in ADHD and the increase in internalizing challenges predated COVID. It didn't start then, it predated it. COVID threw a loop to all of our nice longitudinal modeling. It made it really complex to untangle the effect of COVID for a while. That all said, it was happening before COVID, so COVID alone can't explain it. So what about the idea that ADHD, there's a changing understanding on it. You know, ADHD, talk to any group of teenagers, it has in a really good way been destigmatized. It's now part of a neurodiverse, neuroaffirmative language. And for some individuals, it becomes a very powerful and acceptable metaphor for expressing their experience of being different. And this raises the question, is the lived experience of ADHD symptoms somehow changing? You know, we do things through language. Language changes and language is fluid. Is this impacting the experience of ADHD and then also trickling through to the medicalization of ADHD? Now, quantitatively, there's actually very little evidence for this, interestingly enough. You can do this by using fancy statistical methods to look at how people are responding to specific items in the same questionnaire across time. And there's actually very little evidence that people are responding differently. The patterns seem to be relatively stable. However, that's quantitative stuff. If you do qualitative, some of the qualitative studies suggest a much more nuanced picture, that understanding and expression of difference is changing. And the language of ADHD is one language that is sometimes being adopted to express difference and sometimes how kids are feeling, that they're not fitting in to the systems around them, particularly the school systems around them. This leads on to the, what's happening on the medical side. Is there a change in diagnostic practice? Are we becoming a bit too liberal in our diagnoses? That's best understood, I think, by looking at things like, as far as we have them, external objective correlates of ADHD. And just before we started the seminar, Argyris mentioned a study that showed in ADHD, which is a highly heritable developmental difference, there is a sort of genetic liability to ADHD. And interestingly enough, the amount that genetic liability, its strength seems to be decreasing a bit in time. So the more recently ADHD has been diagnosed, the less clear evidence there is for this genetic liability. An interesting correlate, not cause, but correlate. Now, I'm just going to skip past, just to touch on this point very quickly about how research can help us. You know, it can help in all sorts of ways, not just informing service configurations, but all sorts of ways, just about the fundamental nature of ADHD. And one thing I just want to highlight is, I think, a really interesting thing is we can't think of ADHD as static. ADHD is a remarkably dynamic disorder and challenge that runs many different courses throughout the lifespan. And this was one study I did with some colleagues back in the States. This is looked at 10,000 children, all of whom had repeated research quality assessments of ADHD symptoms over time, and it looked at the patterns of ADHD diagnosis over just 5 years. Now, these are sort of, the two patterns you would expect. So these are individuals who over time met diagnostic criteria for ADHD continuously. We would call this persistent ADHD. And these are individuals remitting who did when they were younger, and then the ADHD was just melting away. These are the two patterns that we'd be familiar with. But this pattern is really a bit of a surprise. Just over a quarter of individuals didn't fit that pattern. Rather, they bobbed in and out of meeting the diagnosis, not meeting the diagnosis, and back in again in a zigzagging fashion that was entirely unexpected. This is very interesting work that I think is important whenever we consider how we plan services and how we conceptualize of ADHD, and also how we discuss ADHD with those who are affected. And I'll just skip to my summary now. Just say that I think there has been an increase in ADHD diagnoses, still probably, and it's a big probably, still probably less than our best research estimates, particularly in adults. So it's still probably under where the true population prevalence is. There's been a possible increase in self-reported symptoms. We don't know what's driving the symptoms. There is no easy answer here. For anyone who says it's just one thing or the other, it's definitely not that. The evidence isn't pointing to something that simple. We need to get quite nuanced here and start to look at factors that are going to get quite a deep dive around diagnostic practice and shifting definitions of ADHD. And it's encouraging to think of the way forwards, and I encourage everyone to look at the very clever and I thought thoughtful reporting out of the ADHD task force, its second call to action, which I thought set out a really nice road plan about where we go next, facing all of these realities. And on that note, thank you.
Thank you, Philip. Lots of food for thought there. So what we're going to do is we're going to hold questions. If you've got a burning question, please put it in the chat. But we're going to invite Naomi to give her presentation now, and then we'll have a very full discussion, I'm sure. I've already got lots of thoughts in my head, Philip. But what I'll do first of all is to introduce Dr. Naomi Fisher. Naomi is a clinical psychologist and author who works with autistic children and their families. And she's going to talk specifically about the dramatic rise in autism across the UK and internationally. So thank you, Naomi, and welcome.
Thank you, Courtney. I managed to unmute myself before I started. Okay, thank you everybody for inviting me to speak today. And just to say, yes, so I'm a clinical psychologist. I have a PhD in autism and a doctorate in clinical psychology, but I'm very much a clinician now. So I'm really talking about what it's like to be a clinician in the current kind of atmosphere. And I think maybe talk about some of the things that have been going on, which I think it's maybe easy to miss when you're kind of more in academia or less on the ground. So I don't currently work in a diagnostic service, but I have worked in diagnostic services in the NHS and also even one of the kind of online right to choose services. But I currently work really clinically with children, either who are heading for a diagnosis or who already have a diagnosis and their families. And I think Philip's just outlined the picture pretty well, that there is a huge increase in both ASD diagnosis and ADHD diagnosis in the UK and worldwide as well. We're not outliers in this in any way. And Philip's told you a lot about the ADHD. Autism really mirrors that. The best study that we have shows a 787% increase in autism diagnostic rates between 1998 and 2018. And from my experience on the ground, I would say there's absolutely no reason to think that has been slowing down since. And this is driven by both children and adults, but I'm going to be talking more about children today. But I'm also going to be talking a bit about what some of the things that I think are going on, which maybe we don't always, maybe as sort of scientists or clinicians, we don't necessarily think about. Because of course, there are lots of different things that could be happening. It could simply be that neurodevelopmental conditions are on the rise, that there are more symptoms. It could be, and in the case of autism, I think there's very clear evidence that this has happened, that there's been diagnostic expansion, so that the way the diagnosis of autism has changed has meant that it's got bigger and bigger and bigger. And that has really happened from 1980, when autism first entered the diagnostic manuals onwards. Every time there's been a revision of DSM or ICD, it's increased the number of people who come in under this umbrella. And of course, the big change that's happened both for autism and ADHD that's really happened since about 2000 is that we've started diagnosing adults. So when I did my PhD, which was 1999 to 2002, it was pretty well unheard of to diagnose an adult, except maybe if the adult had learning disabilities. But now biggest growing group are adults without learning disabilities. And of course, we're asking ourselves then, are we detecting conditions that were previously undiagnosed? I was really interested by one of Philip's last slides there about the way that ADHD is can be a fluctuating condition, or it can be something that someone meets criteria for at one stage in their life and not another. And I think there's some research that shows that autism may also have some of those characteristics, but that definitely isn't how it's understood on the ground. So that absolutely is not how the children and families that I see understand autism and ADHD. To them, autism and ADHD defines them. Well, they would say it defines their neurotype, actually, in many cases, and they would see that as lifelong. So the adults who I meet quite a lot of adults who are diagnosed as well, because they often have children who've been diagnosed. They will see themselves as people who were missed in childhood and who were all the way through their lives, had ADHD, were autistic. Now they finally got their diagnosis, and they will see their children who are being diagnosed as going to be like this for life. And I think that's very interesting, because I think that isn't really where the science has been going over the last sort of 30, 40 years, but that's definitely how the kind of cultural understanding of ADHD and autism has been going. And I think that that's the neurodiversity movement, the kind of neuroaffirmative practice, which again, Philip referred to, has really affected what people think of when we give them an ADHD or an autism diagnosis. And I think the difference can maybe be summed up by saying that when I worked in a diagnostic service, which was well over a decade ago, my supervisor, who had been working for a longer time in the service, said, you need to give parents time to grieve if you're giving them this diagnosis. And even at the time, that felt a little bit I wasn't sure that was really true, because actually my experience has been that the families who are given the diagnosis are generally very happy. It's the ones who don't get the diagnosis who are really unhappy or angry. So there's been a real reversal, and lots of people will say that now. I supervise clinicians who still diagnose, and they will say it's not giving the diagnosis that I'm scared of, rather than giving the diagnosis. I feel everybody knows that there's one outcome that people are looking for. And I think there are a few factors that are going on there, which there's a system since in the time that I've been working clinically. So I started in 2006 is when I qualified. There's been a huge change in how autism and ADHD are diagnosed. So previously it was pretty well through the NHS. You had to go on a long NHS waiting list often, but now there are private practices everywhere diagnosing ADHD and autism. And everybody knows that. So most of the families that if they're thinking about a diagnosis, they would be saying, oh, should we go private? Is it going to be counted by the NHS if we go private? And of course, that leads to a massive difference, because if you are a private service who are diagnosing people, then you're going to be worried about things like your Google reviews, to be really honest, and you're going to be worried about what people will think. And if people are coming to you for a diagnosis and you're not giving them one, then you are likely to get poor Google reviews and to get a reputation as an unsympathetic clinician. So I think the thing is, we don't have to pick one of these answers. There is definitely not one reason why the diagnoses are going up. They can all be true at the same time. I think there's good evidence from Sweden that we're diagnosing more subtle presentations of autism in particular. It's definitely true that intentional diagnostic expansion has occurred. If you look at the way that DSM has changed and ICD has changed, people will talk about wanting to create a diagnostic home for more people, to kind of pull more people in. And because I think a lot of it is because in the US, the health system is driven by diagnosis. You must have a diagnosis in order to be able to get healthcare. And so there's a tendency to always increase the number of people who are diagnosed and never decrease it. Stigma has enormously reduced when it comes to autism and ADHD, and the perceived benefits of a diagnosis have dramatically risen. So before we came on, actually, Courtenay was talking about different diagnoses. I find it very interesting that autism and ADHD are extremely destigmatized diagnoses in contrast to other diagnoses. So often people want these diagnoses. They don't necessarily, for example, want a diagnosis of learning disability actually for their child. They want autism or ADHD. And so that means we've got some diagnostic substitution going on, where people who would have previously got another diagnosis are now getting a diagnosis of autism and ADHD. And I think that we can't really think about what's happening without thinking about this enormous cultural and social shift that's going on. And part of that is social media. And actually, the way I think about the way social media is influencing it is quite different to how Philip was talking about it. because I don't know if anybody has spent any time looking at the autism and ADHD influencers of Twitter and Instagram, not Twitter, TikTok and Instagram. I'm going to just try and play this little video, but if it doesn't work, I'm sure you'll get the impression. Here we are. So this is Ellie
Something that someone
Middleton.
said to me when I got diagnosed was like, nothing changes, but everything changes. Nothing changes in the fact that my brain still works in the same way. I still face the same challenges. I still have the same sort of differences, but everything changes in that I have the context of what those differences are, and I know why, and I know how my brain works. Yeah, I think it's just so validating of like, oh, you know, the reason why I've come up against so many challenges, or I've struggled to form friendships, or I had to drop out of school, or I've not been able to stick at jobs, it wasn't because I was a bad person or stupid or lazy or whatever it might be. It was just that I was different and didn't have that context at the time.
And Philip mentioned ADHD becoming a metaphor for difference. And I think autism has very much also become a metaphor for difference, but also social media is full of people telling you that having an autism or an ADHD diagnosis will make you feel better about your life. Exactly like Ellie Middleton is saying there. She's saying, I realized I wasn't a bad person. It wasn't helpless. It was because I was autistic. And you see this exact narrative happening all the time. Ellie Middleton was diagnosed at the age of 24. By the age of 25, she had written The Ultimate Guide to ADHD, Autism and Neurodivergence. By 26, she'd written How to Be You. And she was on the Autism Curve podcast earlier this year with Radio 5, or Radio 4, can't remember which one, talking about what it's like to be autistic. At the time, she was backpacking in Vietnam. So she represents a very different way to be autistic. In fact, she has diagnosis of both autistic and ADHD, which in social media is combined to be ADHD. And this is she's a new phenomenon, but she's also very much promoting this idea that this diagnosis will help you be the person you want to be. So this is a quote from her: "Learning who I am, an autistic ADHDer, has been the most validated, freeing and life-affirming realization, a realization that I wouldn't change for the world. I'm not ashamed to be disabled. I must go as far to say I'm actually pretty proud of it. Being an autistic ADHDer defines the way that my brain works. It is what makes me me." So I think, and that is what a lot of people are seeing. I see a lot of these videos. I don't actually go out of my way to search them. It's just I'm on social media, and because social media has very quickly learnt that I'm interested in autism and ADHD, I am inundated with videos telling me that perhaps an autism diagnosis will help me feel better about myself. And I think once a diagnosis has become that, then it's inevitable that we're going to have a very large number of people coming through wanting that diagnosis. And I think there are particular things that perhaps make autism and ADHD diagnoses which are prone to this. And one of them actually is that they're perceived as lifelong. I think there's a lot of stigma still about mental health in our society. And somehow autism and ADHD have kind of separated themselves from that. And I think there's something about the idea that this is how I am. This is, as Ellie Middleton says, this is how my brain is. This is how my brain's always going to be. It's not my fault. I think that's a very powerful explanation for people. The other thing that's different about it is that for autism, at least, not so much for ADHD, diagnosis is not linked to intervention. So we have expanding numbers of diagnostic clinics being set up who only diagnose. So when the clinic I worked at was St George's, Southwest London, and we were seeing children. The only thing we could do was diagnose them with autism, diagnose them with ADHD, diagnose them with both, or send them away without a diagnosis. And we had children who'd waited over 2 years to come and see us. And what would happen is they were having trouble at school. They'd be put on a waiting list. They would wait for a couple of years. They would come to see us, and they would be desperate for help. And the only help we could offer them was this diagnosis, because there was no other option. There was nothing else. The service was just as diagnosis. So diagnosis has become a kind of an intervention in itself. It's become something that is kind of cut free from what actually happens next. I know that's not true in the same way of ADHD, but I think it's certainly true with autism. The diagnosis has expanded, and it's understood by most people as being something neurological, which they understand as meaning set in stone. This is who I am. This is who I'm always going to be. And then I also think that the neurodiversity and the self-advocacy movement are actually very pro-diagnosis in a really unusual way. So in other kind of critical mental health movements, other kind of activist movements like Mad Pride, all of these kind of things, they have often been quite critical of the diagnostic system. They have been talking about, understanding difficulties outside the diagnosis. The neurodiversity and the autism self-advocacy movement are very pro-diagnosis in terms of they think they define themselves through autism, but they've also made it into an identity. So they've also widened it way beyond the diagnostic criteria in some cases, but they've kept the name. So I think that means that we have a lot of drivers going on. We have widening diagnostic criteria. We've got massively increased awareness and reduced stigma. Parents sometimes tell me that when their child's struggling at school, it's the reception staff who say, have you thought about getting an autism diagnosis? It's everywhere. I joke that wherever I go, people start when they hear what I do, people start telling me about their autistic child. And it is really true. I've had the plumber, the hairdresser, many people, the moment they hear about it, start telling me about their autistic child. We've got this massive growth in private diagnostic clinics. We've got this place where the autism or ADHD diagnosis is perceived as a key to services. It's perceived as the way you're going to get help at school. And schools will often say that. They'll say, we can't help unless you get a diagnosis. And there are these many, many new ways to be autistic, which are being created via social media. And I think there's also, for clinicians, there's the fact that we want to help people. So if we are in a diagnostic clinic, the only thing we can offer is a diagnosis. If the person is saying, please, we really need help, then you are more likely to just nudge that person over the line and give them a diagnosis. And some of the research in Sweden, where they have these huge epidemiological samples, showed that about a quarter to a third of clinicians reported giving a diagnosis to someone who didn't quite fit the diagnostic criteria. And I can absolutely believe that because I've had that experience myself. I had one particular experience actually where I was very unsure about whether to give a diagnosis or not. And I took it to my supervisor and I said, what do you think? And his only question was, do they want the diagnosis? And the answer is yes, because in the current culture, if they're coming to the clinic, they want the diagnosis. And so people get the diagnosis. So the question that really matters to me, actually, is this dramatic increase in diagnostic rates leading us to better outcomes? Because whereas there's often an assumption that the more children we diagnose, the better that will be for them, that we will have a better outcome, healthier, happier children. But so far, our children do not seem to be doing better than previous generations, despite many, many more of them being diagnosed with autism and ADHD. We know that their levels of anxiety are rising, and there's a real assumption, I think, out there in the kind of social media world that the diagnosis of autism or ADHD is always going to be a positive thing in a person's life, and that even if there's nothing following, often as there is in the case of autism, that doesn't matter because just giving the diagnosis will be enough. But I think that this is a question we really need to be looking at because I think it's crucial because we've kind of got ourselves onto this pathway where it's about providing more and more services. Apparently, there's a study by Ginny Russell, which was showing that between 2009 and 2019, the number of local authorities which had a service which would diagnose adult autism went from very low, maybe 3, right through to 93% of them. And when clinical psychologists often say quite wryly, when we build clinics, the people will come. And they do. We build the clinics and they come. So I'm just going to finish off by talking about a case example, just to kind of bring this to life. And this is a little boy whose identity is very deeply disguised. So he's called Ruben. And he's aged 8, and he's a little boy I saw in the clinic at Southwest London. He's struggling at school, and he's described euphemistically as a handful at home. He has angry outbursts. He's been excluded from school twice, and he's been referred for an autism and ADHD assessment. And by the time I see him, he's been on that waiting list for 2 years. And when someone's been on a waiting list for 2 years, usually things get worse in that time because they haven't had help in that time. So a bit of background about Ruben. He lives in a small London flat with no outdoor space, and he lives with his grandmother, who removed him from his parents when he was 3. What happened was that both of his parents were substance misusers, and his grandmother went to see them one day, found his parents passed out in the living room, and Ruben strapped into his buggy and screaming. And she took him away and said, "That's it. I'm not going to take you back," and fought his parents for custody and has had custody ever since. His school has what they call a zero tolerance approach to behaviour, which means that the children are expected to walk in silence along the corridors. He's expected to concentrate on his work without moving. They also use a whole class reward system, which means that if the whole class behaves well all week, then at the end they all get an hour of golden time when they can choose what they want to do. And you can guess who is meaning that the class never, ever, his class never gets golden time. So Ruben has a reputation as the bad boy in his class already. So I see someone like Ruben and I do an autism or an ADHD assessment. And it's a list of different symptoms, but which are actually dimensional, not categorical, and it takes very little account of the context. So it says, these are the things that is this child behaving in these different ways? And we have an impairment criteria, which currently I think is very inconsistently applied. So in order to get a diagnosis, a person should be significantly impaired as compared to other people. But that's pretty hard to apply clinically. And we know that different clinics diagnose at dramatically different rates. There's a study, I think it's UCL or King's, that came out recently looking at the different rates. They go from about 35% through to 80%. We've also got lots of private practitioners who just diagnose autism. We've got these specialist tools, ADOS and the ADIR. You can go and train in those as a researcher, or you can go and train in them as someone who's got a background in special educational needs, for example, but who doesn't have any wider mental health expertise, which means that there are clinics where people are only able to look for autism, and so that's all they're finding. And the reason I bring it up is because when I met Ruben and when I did the diagnostic assessment with him, I'm also a trauma therapist. I specialise in trauma, actually. And I was hearing his story and I was thinking that this is trauma. There's lots of trauma here. And I could fit him into the diagnostic criteria. That was never in question. He fits them. But I'm thinking to myself, okay, he has never had any input around what happened. His grandmother has never had any input around what's happened. There's never been any attempt to look at whether he might have trauma or even whether he might have something like fetal alcohol spectrum disorder. So if I give him a diagnosis of autism and ADHD, everybody will assume that that is it. That's why he's behaving the way he is. People will tend not to look at the other questions. It will be the kind of happy ending. School will give him some extra support. His grandmother can apply for DLA and for carers allowance. They might apply for an EHCP. There will probably be more compassion and understanding at school. They might find a social support group. Everybody will think this is Ruben's differently wired brain. And it will also probably be understood that Ruben can't change. And this, of course, isn't really consistent with what the science shows us, but that is generally what people think. If Ruben doesn't get this diagnosis, they're going to go back to school empty-handed. His grandmother's going to be really angry. And in fact, his grandmother was quite angry with me. It's going to be much harder for them to get support. Any therapeutic support is going to be behind another waiting list. And they're not going to be able to access local support groups, charities. They can't join in, the local autism network or ADHD network. And they may also go on to seek another diagnosis. They may go on to seek another opinion privately, and Ruben may well get that diagnosis the next time round, because there are many clinicians who use different criteria. And things might get worse at that transition to secondary school. When a child is 8, you're always thinking about there's that looming transition to secondary school. What's going to happen then? But what I don't know is what's going to be the long-term impact on Ruben, because I know that if I give him an autism or ADHD diagnosis, one of the things may be that he starts to see himself as disabled. He may well be given medication. And if he doesn't get a diagnosis, he may start to see himself as bad and naughty. And we just don't really know what the best way is to get him the support he needs. And if I was in a different position, if I had been in a service where we weren't just offering diagnosis, what I would have said is, okay, let's think about what's going on for Ruben and what's going on for his grandmother, and let's think about some environmental changes. For example, I think the expectations his grandmother had were that he was going to kind of, be able to come home and sit quietly after school. Maybe Ruben could have done sports activities after school. Maybe they could have got a mini trampoline for the front room so that he wasn't bouncing off the walls. He was bouncing off something else instead. And maybe his grandmother and him both might have benefited from some trauma work. But the thing is that the only way I can suggest that from my clinic is I'll refer you to CAMS. I'll refer you to somewhere else. And actually, that is what I said to Ruben's grandmother. I said, I think it would be good to look at some other things before we give this diagnosis. And she was really furious with me. She basically gathered up everything, she said, thanks anyway, and she walked out. And I don't know whether I did the right thing or not. And that's the thing as well about these clinics, that you don't know. There's no follow-up. You can't look 10 years, as a clinician, there's no follow-up. So I think we have to be aware that when we give an autism diagnosis, in particular, it has a cultural significance that goes way beyond the diagnostic criteria. And I've already said that 1/3 to 1/4 of Swedish clinicians reported giving the diagnosis when a person doesn't meet diagnostic criteria. The large-scale studies in Sweden indicate that autism symptoms are pretty stable over time, but diagnoses are rising. Children are being given diagnoses with fewer autistic behaviours or symptoms than previous generations, but their parents see them as more impaired, which I think is really interesting as well. I think there's something about this cultural shift. And there's huge pressure on clinicians to diagnose, particularly if you're in a clinic where that's all you can offer. So just as a conclusion, I think diagnoses of autism and ADHD to some extent have become much more than the diagnostic criteria. And there are many factors pushing us as a society towards higher diagnostic rates. At the moment, I don't think we have enough evidence that this is actually improving outcomes for children and young people overall. And it's really true that diagnosis is taking up an enormous amount of NHS resource, and is often not then linked to intervention. Diagnosis is being used as a kind of gateway in the school system. And in fact, when I worked in the clinic in St George's, one of the ways they were trying to cut their waiting list was that the psychiatrist was trying to work out, the consultant psychiatrist who's head of the clinic was trying to work out what we could do to not have this really very long waiting list. And she said that they would only accept referrals from young people who had a concurring mental health problem, as well as the need for an autism and ADHD diagnosis. And it made the local press. People were furious. And she had to back down. And I think this is a story that's carrying on. We're hearing again and again. So those are just the references if anybody's interested. And if you want to keep in touch with me, here is my website and my Substack, and I'm on social media for my sins, where I do my research about what's going on. Anyway, thank you all very much.
Thank you. Wow, that was super interesting. I'm going to hand over to Argyris now, who's going to lead the discussion. I have loads of questions, but I'm sit on my hands for a few minutes and see what else comes up.
Thanks very much. Thanks very much, Courtney. Thank you very much to Dr. Fisher and Professor Shaw for two excellent talks. Using kind of co-chair's privilege to make two observations. One is, when I started in child psychiatry at Eric Taylor's ADHD clinic. I didn't want to become a child psychiatrist, didn't want to have much to do with children at the time. Then I treated my first child with ADHD with medication, and it was an amazing experience. The child was so much better, the family got better. It was really transformative an experience for me as a clinician. Back then, though, the anti-psychiatry movement, or the people who were rather skeptical, the skepticists of the time, were mainly saying diagnoses are social constructions, and you accused us of biological determinism. I never thought I was a biological determinist, but it doesn't matter. It seems now that there's a movement where people want to be biological determinists. They say, I am determined by this thing. This is my biology. I cannot change. And if you don't recognize, so that's one kind of observation. The second one is, for those of us who work in the rest of medicine, you don't often find people come and tell you, I have leukemia. I know I have leukemia. And where the doctor say, well, all right, then you have leukemia. But in mental health, this is not uncommon. People come to you and say, I have autism, or I have something else. And the clinician does give in. And in fact, it was Naomi, what you were saying resonates a lot. There's a study we just published with doing some modeling around these things about how clinicians change their behavior. There's also some very interesting natural experiments with legislation that was passed in America. This is Stephen Hinshaw's studies about the No Child Left Behind policy in America, and changes in diagnostic rates around schools in America as a result of new legislation that created, in the broad sense, incentives around having a diagnosis. So there are very strong cultural elements there that influence both the general public, us clinicians as part of the general public, but also us as researchers, I guess, as a special subset of the general public, and they are all very interesting and very much worth discussing. I do want to say, though, I just looked up the Parliament's website about ADHD statistics. Do you know what the number of open referrals was as of June 2025? About 700,000, to be precise, 668,370 people waiting for an ADHD assessment as of the end of June 2025. So not being precise about our concepts and constructs and not doing the necessary research work does come back to bite us. It has come back to bite us now. Anyway, I'll open the floor to questions. And Courtenay, why don't you make a start? And I'll ask my questions later on after I've made all these lengthy observations. Then we should open the floor to the others, of course.
So one of the things that Naomi said that really resonated with me is you have these diagnostic specific pathways. People are assessing for autism, they're diagnosing autism. I think they're not taking perhaps that more holistic picture. And as someone who knows, well, certainly when I trained back in the day, many people with autism had co-occurring language challenges. And I don't think that's so much the case anymore because of the way that the diagnostic pattern has opened up. But very few clinics have speech and language therapy input into them. And I think that's a mistake. And the other thing that I think that leads to is this expectation that you're going to get this diagnosis. And I just wondered what would happen if we had, neurodevelopmental clinics where, instead of saying, people come in saying, I'm here because I know I've got autism, basically the whole ethos is there's something that is different. Our task is to try and figure out what that might be and what impact it's having. And maybe that would kind of diffuse some of the anger and frustration, probably not, but allow that more kind of assessment in the round of all the things, the context, the other possible diagnoses, what is creating the impact and what might the benefits be of having this diagnosis. So is there value to having these diagnostic specific pathways? It's almost like assuming you know what the diagnosis is before you've even done the assessment.
I don't know, Philip, would you like to respond to this as someone active in creating services as well at the moment, I guess?
Yeah, it's a great, like the whole question of is there a case for diagnosis, provided the assessment that's done within that diagnostic pathway is thorough and ranging. Of course, it makes sense to have a pathway for certain kids just because of how limited services are configured. Currently our estimate is 30 to 40% of mental health care need in the community can be met with our existing resources. That's not going to expand to meet 100%. We've got to get smart about how we allocate these resources. Doesn't mean what's happening just because it's the initial assessment should be broad ranging and encompassing, and it shouldn't just be going through, well, this is an ADHD pathway. The only questions I'm asking, the only thing I'm being curious about is ADHD. That's not a good standard of care in any system, nor what we should be training our next generation of clinicians to be doing. Multidisciplinary input can help a lot in that process, as you were mentioning, particularly around autism and some of the very tricky boundaries with communication differences, all really important. But no, single diagnosis doesn't matter, the configuration, provided the people who are providing services are well trained and do the proper basics assessment.
Thank you. I wanted to move on. I see there are 3 hands up by 3 well-known and distinguished researchers. I would want to encourage the less luminous people like myself to also dare to speak. I will start with Professor Heyman. Isabel.
Thanks, Argyris, and thank you to both the speakers. Fantastic talks. I want to ask the impossible question: how are we going to solve the problem of the really severe cases of children with ADHD not getting stimulant medication? And I see children like this every week, and I don't work in a specialist neurodevelopmental clinic. I work as a liaison psychiatrist in a general hospital. So I see children with physical health problems, with other mental health problems, with suicidality. And, I don't share, Phil, really. I think the ADHD task force report is a tour de force, but it describes the problem and it describes a whole plethora of possibilities. It mentions stimulants. I just counted rather nerdishly. It mentions them 9 times. But, you know, we have one of the most effective treatments in the whole of medicine with very minimal side effects. And, you know, I saw a 9-year-old boy 2 weeks ago who was already in forensic services because of his degree of impairment. And I mean, I probably spent 8 hours getting him into a treatment pathway with everybody telling me he'd jumped a 2-year wait list. And so, you know, Reuben, Naomi, I would argue that there would be nothing to lose for Reuben to have a trial of methylphenidate. It's not going to solve all his problems, and I'm not for a moment saying that these children don't need psychosocial interventions, but I think it's neglectful that he's not being offered a trial of stimulants. It could be transformative, as Argyris said. We don't know if we don't try. And if this was a drug with massive side effects or problems, then of course we wouldn't. But, you know, my final point is that, you know, we hear in the news this week, adult ADHD clinics are closing because of their wait list. And to me, this is to prevent, I guess, the moral injury of the poor people who have to run them. They can't stand it. But I think none of our best academic brains are thinking about how we fix this. And I had lunch with Argyris last week, and I said the outrageous thing that I'm moving towards thinking that stimulants should be available over the counter. You know, statins they have a larger effect size than statins. Not saying we shouldn't provide some sort of monitoring, but I think nobody's thinking outside of the box, and I'm going to throw that out there to see what you think, Phil.
Thank you. Can we have quick answers from both, actually, if possible, Naomi and Phil?
Me first? Yeah, I mean, I think there is a disadvantage to going straight on to putting a child onto medication saying they have ADHD because of the way everybody else around the system reacts, which tends to be, okay, we know now. And that's the problem in what I see clinically anyway. And I'm not at all saying that there are, but I think another thing you've talking about there, which I think is a really serious issue, is, and it's the same in autism, we've got this group of really severely disabled children and young people, and we've got a waiting list full of people who are not that severely disabled for the most part. And that is a serious problem because we have got people who wait 2 years for treatment that they really need, but at the same time the diagnosis is being promoted as a kind of answer to everything to other people as well. And I think that's something we have to grapple with clinically. I don't think we've got, as professionals, I don't really think we've got a voice properly in the cultural soup that is making up neurodiversity and autism and ADHD. I think a kind of scientific professional voice is quite absent on the kind of way that most people experience these things.
Thank you. Phil?
Yeah, it's absolutely psychostimulants, you know, they are the envy of most of child psychiatry. They are great. They are great. And for most kids with ADHD, in the short to medium term, they are fantastic. The issue becomes the longer term. There's several things that happen over time, which you'll know from the longitudinal observational studies. Kids just stop taking them. And that's not because they don't work even sometimes. It's not because of an accumulate. They just kind of stop. It is fascinating to know, like about 70 to 80% of kids, even whenever we prescribe them, even when we provide good psychoeducation, will stop those medications. There just isn't that adherence. It's said we definitely can offer it, and we need to think more cleverly about not just the short to medium term outcome. How do we show benefit over time? And what's going on that's not engaging people over time? The other aspect of that is it is only part of our armamentarium. It is symptom relief. You know, I'm very optimistic. I think we can do an awful lot better than temporary symptom alleviation if we get to the neural mechanisms that are really driving some of these symptoms. Our current efforts have added up to a big fat zilch. You know, we're not getting somewhere. We need to get cleverer. We need to start looking at, you know, fractionating ADHD, looking at the commonalities with some of the other mental health challenges, getting to a mechanistic level, targeting mechanism. That, I think, is the long-term solution to this. In the meantime, absolutely, stimulants are part of our armamentarium. We need to have more curiosity as to why aren't they people taking them in the long term.
Thank you. Just to mention a couple of the big Swedish studies have shown that even for those who take them, say, temporarily, for what, those who take them to the extent that you can match them to those who don't take stimulants do seem to show better outcomes in the long run, particularly in matters forensic. So there was a big New England Journal of Medicine study a few years ago and a few other ones that seem to demonstrate that. Obviously, there are always problems with observational studies, but then it may be that trajectories are being shifted at a certain point for the better. Maybe. I'm playing devil's advocate for both sides here. I'm trying to, for the sake of the conversation. Professor Skews.
Yes, thank you, Argyris, and thank you both for very stimulating talks. Brief question aimed at Philip. And I heard Anita Thapar on the radio last week giving her analysis of the ADHD task force. Both you and she talked as though there was some sort of limit to the proportion of children who deserved an ADHD diagnosis, and of course, Anita was talking about adults as well, at around 5%. Which led me to consult the CDC data on the prevalence of apparent ADHD in the US, which has now reached 15% among boys in childhood to adolescence, an overall level of about 12%, and half of those are on medication. So where is the evidence that they've reached the saturation, shall we say, of ADHD, perhaps some overdiagnosis? The more severe cases, the prevalence is around 5–6%, according to CDC data published last year. Is there evidence that this has been beneficial to school children in the US? Of course, I appreciate the prevalence varies from state to state, but overall, I guess, Philip, you're in a position to be able to take a look at this.
Yeah, the sort of 5% figure, two different prevalences here. One is the medically recognized and the system saying this child has ADHD. That's your CDC. That's what they're looking at. The 5% is the meta-analytic summary of research quality diagnoses done at a population level, where a team of researchers gone out, interviewed 1,000 kids, using kiddie SADs or some other structured tool. They are properly trained, they assess impairment, they assess pervasiveness. They're properly trained researchers with supervision. So these are research quality diagnoses, which I think in some way that's all we have. That is still our gold standard because we have no objective metrics at all. We have nothing in cognition, brain, or genetics that can inform our diagnostic practice yet. Our gold standard is the research, is the diagnostic manual tool as applied by a trained supervised researcher. That's where the 5% estimate comes from. So that would suggest, that's what's floating around. Absolutely, national variation around that is quite marked. And that speaks to the system level configurations, which I think is what Anita was tapping into, like, what are, and others have tapped into, what are the incentives? What are the drivers of people going home disappointed when they don't get a diagnosis of ADHD? Surely we can be more intelligent about our service configurations so that if a child comes away with a diagnosis of a speech or language challenge or a problem with trauma, that triggers systems to be every bit as supportive and as enriching for that child as it seems to for ADHD. That's a systems level solution, which I think the ADHD task force was tapping on. I think we do need to look at how the systems are interacting. That will have a beneficial effect for kids, I think.
Thank you. We have just 5 minutes. I'm going to read out, before I go, Matt, I'll come to you in 1 second. Just want to read out something that is in the chat where Dr. Raj, a colleague, child psychiatry colleague, is saying that the way patients and families are listened to may have an effect on the acceptance of the diagnosis. So please do all read this very interesting point that our colleague is making in the chat. I don't think it was meant to foster to be a question rather, but to foster discussion and thoughts. Matt, Dr. Somerville, can I ask you to ask the question and then for a very quick answer by our speakers? Matt.
Sure, yeah, thank you both. Really interesting content and so nicely presented as well. So a question for you, Philip, based on I found those charts really interesting at the beginning that were disaggregated by age. And I was wondering, I was thinking through those potential drivers you presented, how many of those drivers go some way towards explaining these different trajectories? Like I could think of the neuroaffirming language. Maybe you can explain that that's more likely to see an increase in younger adults, but what are your thoughts on the other drivers?
Yeah, that's a great question. I think one of the, given we're tied to observational data, one way of trying to get to something that's more likely to be a cause is to see, does it have a differential impact in groups that are particular movers or drivers? There are other very interesting trends and diagnoses that center around ethnicity and gender. And those are, very, very key things. So it is that chart, the one that goes up like that, it is fascinating. If you look at that, under 5 rate of diagnosis, for example, is actually stable, if not going down. So if you say, well, if it's something about increasing level of ability to conceptualize of the self and to express yourself to a system, that would be a nice explanation. Under 5 don't have that capacity, generally speaking. Kids have a bit of an emergent one, and teens have got it in spades. So that would explain that. So there are ways in which we can look at the different subpopulations and then see how observational cause intersects with them. It's a good strategy for trying to pull out what's more likely. It says, for example, that COVID's probably not going to play too much of a factor. Things like this. There are differential impacts.
Thank you very much. Just one last point, again, using chair's privilege. Things that are of small effect size, when scaled at the population level, can add lots of cases to clinics, right? So they are causally maybe negligible in the grand scheme of things, but they, something like even something of an effect size of Cohen's d 0.1, if it's scaled to the millions, can clog up clinics. And we may be having a number of small effects kind of coinciding, if that makes sense, and some of them may be causal, some may not be. So it's quite an interesting situation. I want to thank both Philip, a world expert in this area, and Naomi Fisher, who's so knowledgeable about both services and the clinical realities on the ground about these things, for 2 excellent talks. Yeah. I also want to thank the public, the people who took part and asked all these very clever questions. And so please do applaud our speakers. And my co-chair, Professor Courtenay Norbury, I'm sorry, and all the people who organised this. So
I think we should say the next meeting.
Yes, please do.
Yeah, is the 10th of December. And the topic is youth justice. So please join us on the 10th of December. And yes, thank you. I think we could talk all afternoon, but I suspect we have other meetings we must go to.
Bye.
Thanks so much.
Thank you. Bye-bye, everyone.
So interesting.